associate, some people always associate hyperlipidemia with the fact that somebody is unhealthy, right? Like that's usually what we think about. What I want you to understand is that this is one of those conditions where when you're talking to the patient, you're going to have to be very patient with them. Because a lot of it is going to be based off of lifestyle modifications, and a lot of people do not like to make lifestyle modifications. They'd rather take medicine for some reason. So if you try not to get frustrated with your patients. I worked at a clinic, and this lady kept coming in, and she was so out of control. And then we would ask her, the provider asked her to keep a food diary. And she's going to McDonald's, she's going to Burger King, like she is living her best life that was about to be shortened because she kept clogging her arteries. And I was like, ma'am, like, what don't you get? And he was so patient every time he talked to her. And I was like, I couldn't have this job. So, because my face, I would just look at her and be like, okay, I'll see you next appointment if you make it. Like, that's what I would say to her. Because she just wasn't helping. He was like, oh, did you try to walk around the neighborhood? And she's like, no, I didn't want to walk. I was like, okay. Like, and so after she left, I said, how do you do this? Like, how do you try to help patients like this? And he's like, I'm just hoping that one of these months that she comes, that she'll hear what I'm saying. And then we had another guy who looked just like most of us in this room, super healthy, worked out all the time, but he had it in his family. So genetically, he had, and I'm looking at him and I was like, man, this man's arteries are like, it was bad. And I just felt so bad for him because he was so frustrated. He ate right. You could tell, he looks like all he does is work out and eat salad. So I was just like, man, this is crazy. But that's genetic. So you can't look at a patient and tell what's going on. Just try to be patient with your patients and be understanding that lifestyle changes are the hardest thing that you're going to have to get somebody to do. Taking medication, it's hard to get them to do that, but they're like, I can still eat my McDonald's if I take this pill. I'm taking the pill so that I can eat McDonald's. Instead of, maybe if you stop eating McDonald's, you don't have to take the pill. People don't think that way. Most people don't think that way. So be patient, be understanding, be empathetic as well, because there's a lot of things that go into why some people choose to eat what they're eating. If they need something quick because they're always busy, if they don't have a lot of money and it's cheaper, whatever the case may be, be very patient. Just try to educate them as much as you can, because we're trying to keep our patients around for a long time. You don't want them to die on you, okay? Off of my soapbox, back to the slides. All right, so your physiology. We know that the major lipids that we have our cholesterol, our triglycerides, and our phospholipids. We need them, even though we think of them as bad. They're only bad whenever they are not regulated, whenever we have an imbalance, whenever we have exogenous sources adding on to what we are endogenously making, right? So if I am choosing to have a bad diet, that's whenever I have the dysregulation of these lipids that we have in our body, and then that's when I can cause issues. Also, like I said, genetically, I can be passed down from my wonderful mother or father their issues, and it's called familial hypercholesterolemia. Like, there's several different names that you can go through with that. So they can be familial, or they can be from me making these lifestyle choices. Either way, we have to treat our patients. So cholesterol, we need it, right? It is a precursor for us to a lot of different things. Definitely our steroids. You also have it for our bile acids, which help transporting things in the liver and all that good stuff. And then with our triglycerides, we always think of the triglycerides as being bad, right? But we need it for our muscles, for energy. And then you have your lipoproteins, which I just like to think of them as your carrier proteins to get things around the body. Not going to go into all of that good stuff with you, just knowing that your lipoproteins are what are carrying your cholesterol and your triglycerides around. Exogenous means from an outside source, right? So not something that you're endogenously making. It's coming from your diet. So this is essentially the pathway of how we are forming cholesterol. And our favorite class of medications that we're going to talk about, which is our statins, is targeting what you see in that first circle, the HMG-CoA reductase, okay? So when we are trying to decrease cholesterol levels, this is the pathway that we are attacking, and you are having very, very good results when you use statins because of how high up in that chain it's stopping this process, okay? So very good medication that works, and we are targeting our cholesterol synthesis, which happens in the liver. Most of the time, this happens at night, which is when we usually get more of that synthesis occurring. So we'll talk about with our statins, most of the time you'll take those at bedtime because that's when you have the most production. With a lot of the newer medications and when you're taking them in a higher dose, as far as the statin, it doesn't matter if you take it at night or not. You also have those people who are like, I work overnight, do I still need to take it at night? No, take it when you go to bed. Like, just be specific with your patients because they don't know. They don't know. All right, our lipoproteins, we just talked about some of them. So you have your VLDL, which is your very low density lipoproteins. The higher the protein content, the more dense the protein is. So our VLDL, these, we don't want them. They are bad, and they are the precursors to our LDL, which is what we usually measure, and we're trying to target with our statins. That's what we're trying to reduce. So you have your VLDLs, your LDL, and your HDL. Your HDL, you see that there's more protein in your HDL, and that's what we like to call our good lipoprotein. If you can have a higher HDL, the better. You do not want a high LDL, okay? As we go through, we'll see that and how some of these medications that we have can increase our HDL level while lowering our LDL level and vice versa, okay? So from this slide, I just want you to know the different types. I don't need you to remember percentages of triglycerides, like what composes that lipoprotein. Just very low density, you have low density, and then you have high density. Understanding that your high density is good, your LDL is no good, and that your high density also is what takes the cholesterol from like your circulatory system and takes it back to the liver for it to break it down. So that's why we call it our good cholesterol. This is essentially saying exactly what we just talked about. So you have your VLDLs, IDLs. You don't really see these used a lot or talked about a lot, but they also are helping with transferring cholesterol, kind of like LDLs, but just think of it as like the intermediate cursor to the LDL. Your LDLs, again, bad, right? So you see the reason why we're calling it bad is that they're the ones who are mainly responsible for that plaque formation that we get in our arteries. And then they can lead to lesions or where like they will rupture. So that's what the arthrosclerosis is, or an arthroma. And essentially it is that abnormal accumulation of different materials and less gunk built up into the artery that can be reversed with the proper diet or with us using medications. There's also procedures where they will go in and help the patient kind of, if it's very, very bad. We don't usually go in to do anything with that. And then your HDL, good cholesterol. Remember how I said it's the reverse cholesterol transport where it'll take it out of the circulatory system and put it back in the liver for the liver to break it down. It's also very good because if you have a plaque, it will go and get some of those deposits out of the plaque to take it back to get it broken down. So HDL, we like it. All right, our pathophys. Am I going too fast? No, okay. Pathophys, you have your, this is just our terminology that we talked about. So I'll start with hyperlipidemia because people get confused with hyperlipidemia and dyslipidemia. So hyperlipidemia is just saying I have high levels of lipids. Whereas when you're talking about dyslipidemia, that's just like the fact that there's dysregulation in what we would want our normal levels to be. So elevated LDLs, or if you have too low of HDL, right? So we have high of our bad and low of our good, which is what we don't want. We want that to be reversed. So that's just when you hear somebody say dyslipidemia, that's what that means. And then we know that you can have several different things occur to you if you're having these scleromas building up into your arteries, right? So you see the coronary artery disease, your heart disease, there's so many things that can occur from us having these buildups. With our triglycerides, you can see that you can get the pancreatitis. We usually relate it to coronary heart disease, but it's not proven yet if that is an actual cause. We would want to be on the safe side, because while they do all of their research and all of the things, if we can control that diet and if we can reduce triglyceride levels if a patient has high levels, we need to do that. This is just showing you a picture of what the atherosclerosis looks like, and showing you the difference between a stable plaque, which has that harder fibrous cap on it, versus one that is ruptured or about to rupture. That cap is going to be thinner, and then all of that, our lipids and everything that we don't want in our circulatory system either, but if it's in our circulatory system, at least we can remove it. That will then break off, and then we will hope that our HDL can help come and get that back to the liver for us to get it out of our system. So this is just showing you what a ruptured plaque looks like versus a stable plaque. Hyperlipidemia. So for some people, like we were saying, it can be genetic, and we see that's a pretty high number, 1 in 500, because a lot of people have hyperlipidemia. 1 in 500, that's what we would consider primary, genetically, right? They cannot control it. Versus secondary are the things that I can control that have caused me to have hyperlipidemia. So obesity, diabetes, if I chose to be someone who drinks, liver disease, renal disease. Now some of these things, like I didn't try to cause myself to have like liver or renal disease, right? But don't mix it up with something that is considered primary. Primary is only talking about genetic. You are genetically predisposed to having this condition. And then looking at our different abnormalities that we have, that's that Fredrickson-Levy's classification system on the bottom. I don't need you to know like which lipoprotein is elevated in which type, okay? Just understand that there are different types that can occur in the patients, and these are the ones that are genetically passed on. These are not ones that are caused, like, that are a result of the secondary causes that you see listed here, okay? So, with this chart, what I am needing for you all to remember is the type that they're having, not necessarily the name. Like type 1, I'm treating with the diet and I don't need any drug therapy. So look at the type and the treatment. Okay? Just the type and what you need to do to treat it. Don't worry about which lipoprotein, because I just told you that on the slide before, and the description of what's going on. You can read that if you would like to, but I don't need y'all to differentiate between what types. Okay? So for instance, if I said we have a patient who has type 2A, which is the most common type of familial hypercholesterolemia, what would you use to treat this patient? And then you would say, oh, I would give them a statin, or I would use this, or I would use that. Okay? So I'm not even going to sit here and read this to you. What you see is, it's going to be all of the meds that we go through. It's just nice here in a chart, but we're going to go through all these meds. All right, so starting with our treatment. There are several different guidelines that are out there for you to use, and some of them are more stringent than others. Depending on your patient's history, which is why you need to talk to your patient. You can choose which goals you want them to hit. Keep in mind that for some people, they kind of like a snowball effect. So if I came in and my LDL levels were at 300 and you set me at a goal of less than 70, it's going to seem like it's taking me forever to get to less than 70. So say, okay, we need your goal to be less than 100. And then when they get to 100, be like, I really wanted you at less than 70. And then change it. Because a lot of patients will feel like it's something that's unattainable and they won't even try to get to it. Okay? So you kind of want to give them some deposits in the bank to give them that momentum to keep going. So if you see that somebody is really, really out of range, depending on what is going on with the patient, some patients you can't be nice to them and you need to be like, you need to be less than 70 because your triglycerides are at 600. Like, this is not good for you. Some people you're going to have to be very tough with, but some people, most people, if you kind of give them a little, it'll get them a lot further down the road. So what you can see on this chart is that they have, for instance, their LDL level with the ATP guidelines at less than 100. In the clinic that I was in, when they looked at the AHA and ACC, it was less than 70. And most of our patients were put on a goal of less than 70. If they are older, sometimes people will be more lenient. You'll see this also with like the diabetes guidelines, same thing. They'll give you two different, everybody has a different recommendation. You pick based off of what your patient is going through and the demographics of that patient, okay? So all I'm just trying to show you here is that there are different goals that you can reach based off of which resource you're using, okay? You don't need to learn anything about this slide. Just know these are your resources that you have for you to use to guide yourself on what your goals are going to be. This is a link to what is called your 10-year risk calculator, which we're going to talk about on the next slide. So what you're trying to do is you have people who will have, you know, some issues with dyslipidemia. And what you're going to do is you will have them come in and you will pull up this calculator and you can click all of the things and it'll give you a score of what that person's 10-year risk is going to be. And then you will choose if you need to give them a statin, what dose of a statin you need to give them. Is it a high intensity, a moderate intensity, or a low intensity statin? And then you'll move from there. So what you see here are all of the things that are the information that you need to put into the calculator. So your non-modifiable, your age, your sex, and your race, that goes in there. And then you see your modifiable things, which are going to be from labs that you get from the patient and when they come into the office visit, like their blood pressure, all that stuff. That will be the second part of it. And then it will spit you out a number, and most of the calculators will also tell you which intensity statin you need to use, if you need to use one at all. Okay? So that's what this link is for. So, looking at our prevention and what goes on with that. Primary prevention means this person does not yet have ASCVD. We are trying to prevent them from having ASCVD, okay? So primary prevention versus your second slide, which is secondary prevention, that means they already have it, okay? So to break down this chart that you have to remember, I wanted to hide because whenever I tell everybody's face is like, what? Okay, so I'm going to break down the chart for you. It's really not that bad. This you are going to use a lot because a lot of patients, again, have issues with this. This is going to be a highly treated disease state that you guys are going to be dealing with. So if you have a patient who has an LDL that is higher than 190, so go all the way to the right of the chart, those boxes all the way to the right. Oh man, this thing. Did y'all find out who stole the thing? The clicker? Okay, So the one that is up on the right, you see the green boxes where it says LDL greater than 190. These people, you are not giving them a chance, okay? They're going to be on a high intensity statin. You are out of control, your LDLs are very high, and I'm trying to get you reduced, okay? For your patients who are between the age of 40 and 75 and they have diabetes, you're going to give them a moderate intensity statin, okay? If they are, if they have diabetes, you said, okay, moderate intensity. You can choose to use that calculator, the risk calculator, to decide if you want to increase them to a high intensity statin. You can also start with a moderate and see if their levels kind of decrease to being within goal. That is the purpose of using the calculator. You're using all of those risk factors to see, do I need to put this person on a high statin? With statins, which we'll talk about a little bit later, the reason why the intensity matters is because of the side effects of the medication. So usually when you have somebody in a high intensity statin, they'll have a lot of myopathy or like muscle pain. They can get rhabdo. So it's very, a lot of patients are also sensitive to it. So dealing with high, moderate, and low intensity statins is very important, and you're going to have to learn those doses, which I'll talk to you when we get to that slide. But that is why you will then use the calculator to say, do I need to put you on high intensity if you have diabetes and you're between that age of 40 to 75? Okay, now going back to the left side where you see your age of 0 to 19. We're thinking that these patients are young enough, you're resilient enough. All other things aside, like if they don't have any familial diagnosis, then you can say, let's focus on lifestyle changes for you. I don't need to put you on a statin. I don't need to go to the risk calculator to see where you are. I'm going to try to control you with your diet first. If they have a familial diagnosis, you're going to put them on a statin. With statins, most of the time, people do not start them until the patient is over the age of 18. It has been done where people use them under the age of 18, but it's not something that, if you're in that situation, you probably would want to refer them to somebody who specifically deals with all of this. If I were you, young PAU, when you get done with this, I would not give a less than 18-year-old a statin. Let somebody else do it, okay? Age 20 to 39, okay? Still with these patients, we're trying to get them to do lifestyle modifications, but we're also going to use our risk calculator to see where they're at. You're also using the risk calculator to kind of scare them. It sounds bad, but you don't want to get them to where you actually have to put them on the statin. So you'll do that risk calculator to let them know, like, hey, if you don't change these things, and you can always use the risk calculator to do that for a person, even the younger ones. But if you don't change these things, then this is what will happen. If they are someone who is, if they have like a family history, not that they have familial diagnosis, but if they had a family history, or if they have like some type of ASCVD event in the past, then you can consider putting them on a statin. That's a conversation that you can have with the patient, and you can recommend it. Moving to the next box, you're age 40 to 75, and they have that LDL. You see the goal here is 70, not 100. So if they have an LDL that's over 70, and they don't have diabetes, because remember, if they had diabetes, we were going to put them on that statin. So these patients don't have diabetes. You're looking at your 10-year risk calculator. You're going to have to use it, because those boxes that we talked about in the green, that is, you don't need your calculator for that at all. You are only needing your calculator for these patients because they don't have diabetes. Them having diabetes automatically makes them have to be on that statin. Okay, so these patients that don't have the diabetes, so you're going to put in your risk calculator. Your risk calculator is going to spit out a percentage to you. You have less than 5, which is your low risk. You're greater than 5, but less than 7.5, which is your borderline risk. 7.5 to less than 20, which is your intermediate risk, and then your high risk is over 20. I'm not trying to make you remember the percentages. I will tell you what risk they are, okay? What I need you to know is based off of that risk, what are you doing? How are you treating your patient? So if they're a low risk, again, we're just going to talk to them. Oh, you know, your diet, blah, 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 lifestyle modifications. They're still good. They're not horrible. Now, if you see that you have somebody who is a borderline risk and they have those risk enhancers that are over there in that box to the left, that gray box, so these are things that would predispose them to potentially later on in life have a higher ASCVD score. So you're trying to prevent it, and you could potentially then put them on a moderate intensity statin if they have some of those risk factors that are over there to the left. If you are in your intermediate risk, okay, looking at what they have going on as far as the risk enhancers, again, that are in that box, okay, you can then choose to do a moderate intensity statin to reduce it. My thing with this group, again, if they have a lot of modifications or risk enhancers, you can slowly choose to increase your patient to a high dose statin. Okay? If they only have a couple of them, and based off of this chart, just know if they have the intermediate risk that you're going to do a moderate intensity statin. And then if they have a high risk, we already know, we're throwing the book at them, they're going to get a high statin. Most of the time, you start low for them and go slow. Low for these patients, though, would be a moderate dose. Moderate dose. With this, what I saw in practice, the provider would start with a high dose because the patient was so high and we're trying to just get that LDL level down, and they would wait and see if the patient complained of any muscle pain. That is what I would suggest to do. So on here, I know that it doesn't indicate it, but what you are supposed to do in this situation, if you have somebody who is in your high risk category, they're going to get a high intensity statin. Okay? Make sure you talk to that patient to let them know about the side effects and how they're probably going to need to let you know if they experience any muscle pain at all, because then you're going to have to go over some techniques that we'll talk about to decrease that dose. Now, if you are not certain, you don't know what your risk is, or the patient is still kind of going back and forth, oh, I don't want to take any medicine, they have what's called a CAC score. And that's a coronary artery calcium test that they do. They actually go in and it's like it's a CT scan essentially of the heart. Some patients, after they have it, will have providers go in and kind of clean it out for them, which is cheating. But you get the CT or the CAC score. The higher the score, the more calcium buildup they have. If you are using the CAC score, and if they don't have a 0, most of the time you're going to putting them on a statin. Is that realistic? We usually use the calculator, unless the patient is just very adamant that they don't want to take a statin. So just for your awareness, there is a CAC score as well that can be done for you to actually know what is going in the patient's heart and how much calcium buildup they have in their arteries. Oh. Okay, and then after this one, we're going to take our break. So this was your secondary prevention that we talked about. So these patients, they already have the ASCVD, and what we're trying to do is know which statin to use and when. There are some things that they consider. You see how to your left, it says ASCVD, not at a very high risk. What they consider high risk is if their LDLs are still over 70, if they've had some MI, stroke, peripheral artery disease, those people are of course going to be more prone and more high risk. So I'm not expected for you to know all that. I will just tell you if they are not at very high risk or if they are at very high risk, and then you'll need to know what to do. Okay? So this is the other you need to know it chart. So based off of their age, if they're over the age of 75, or sorry, not over the age of 75, they're getting a high intensity statin. And then you see if they can't tolerate it or if they're still not at goal. So if their LDL is still over 70, then you're going to add the ezetimibe to their treatment. If they're over the age of 75 and they can tolerate a high-dose statin, or if they were already on a high-dose statin, then they're going to continue it, is essentially what that's saying. If they're over the age of 75 and they cannot tolerate a high-dose statin, then you're going to have to put them on a moderate, because something is better than nothing. Okay? If they're at very high risk, you see you're going to do high-intensity statin at the maximum dose that they can have. If they can't tolerate the high-intensity statin, again, you're going to push them to the highest dose that you can get them in your moderate intensity statins. So you see that if they're on their maximal dose that they can tolerate, if their LDLs are still over 70, then you're going to add your ezetimibe, which is the same as what we just saw on the other side, right? We just saw that if they weren't high risk. So if they're above goal, you're adding ezetimibe. If you still cannot control that patient, after you've added the ezetimibe, then that's when you would consider adding the PCSK9 inhibitor. These are a newer class drug. They're super expensive, so a lot of people, they kind of shy away from it. So you're trying to make sure that your patient is adherent, that you have maxed out your statin dose, that you have already added ezetimibe before you try to add on the PCSK9 inhibitor. Okay? The dashed line is just telling you that you could, if a patient is not managed, and if you can't try or they have a contraindication to taking a statin or ezetimibe for whatever reason, you could directly go to the PCSK9 inhibitor. That is very rare that you have to do that, but in some situations you will have to do it. You'll probably have to do a prior authorization when it comes to that. Okay? So essentially what you're doing, high intensity statin for these patients, adding on ezetimibe if they are not at goal. If they continue to not be at goal, when you are looking at your very high risk, then that's when you will add on your PCSK9 inhibitor. That is a quick summary of what this is telling you. Okay? Go ahead and take your 10 minutes and come back. For the slide. Was that a good hint or a bad hint? Okay, so for this one, y'all are needing to know the intensities of the statin. What is important about this is you see that you can have, for instance, a atorvastatin, which high intensity dose is 40 to 80 mg, right? If you decrease that dose to the 10 to 20, it's considered moderate. So you're going to need to know the dose range to know what's considered high, moderate, and low intensity. Okay? What I would suggest is remember what is high, remember what is low, and then everything else is what's intermediate. Okay? Because trying to remember all of those ranges, it's a lot. So that's how I remember it. I remember what's high and I remember what's low. What you can notice and why the intensities matter and why we hear these things and what will kind of bring the picture back together for you is you see with high intensity, what we're trying to do is lower that LDL by at least 50%. Okay? So think about it. If I have super high LDL levels, that is why you're putting me on a high intensity. I'm trying to cut that by at least 50%. When you're looking at your moderate, you see you get a 30 to 49% reduction. And then when you're looking at your low, it's about a 30% or below reduction. Some people will ask you what is the LDL lowering percentage and stuff like that, because it's trying to see what your goal is for you to know, am I okay with leaving my atorvastatin dose at 40, or do I need to increase that dose to 80? Do I need to maximize it out, or did I get my 50% reduction? Some providers will also just increase that dose if the patient is still not at goal. Okay, so this whole chart, just know it. Know it. I would, like I said, because some of y'all trickled in after, I would remember what's in high and remember what's in low. Okay? What is bolded is just because this looks confusing. What you see in bold is the doses that were studied. Y'all aren't worried about that. So just know high intensity is atorvastatin 40 to 80 milligrams, rosuvastatin 20 to 40 milligrams. Okay? Ignore the bolding and not bolding. That's just what they did in the study to say this is what the percentage reduction you're going to get. All right, now looking at our meds. So here are our different medications that we can use. You have your HMG, CoA, enzyme reductase inhibitors for your statins, your fibrate or your lipoprotein metabolizers, or that they alter your lipoprotein metabolism, your fibrates and your niacin and your PCSK9 inhibitors, your bile acid sequestrants, BAS for short, you'll see it as we move on. These are your C drugs, okay, and then your cholesterol absorption inhibitor, which is your ezetimibe that we were talking about, you would add if your patient is at goal. This is what we're going to be adding to our statin. What you're seeing to the right is essentially the drug and what type of reduction you will get or increase you will get if you use that class of medication. So you see why our statins are bomb, right? We can lower that LDL, like fantastic lowering of the LDL. You get some increase of our HDL, which is good, and it's also lowering the triglycerides. But if I had a patient that I'm really trying to lower their triglycerides, and that's my focus, it's not so much their LDL, which medication based off of this chart would you pick?
Fibrate.
Right? So this is what this is showing you. It's going to be a summary of what we're going to start going through when you get every single drug outlined, following. So this is a good summary slide for you to just kind of go back and say, all right, what class is for this? What class is for that? What class is for that? Okay, but it's also going to be seen later. Niacin seems so fantastic when we're talking about HDL. It's usually not something that we would give to just raise an HDL level, but the side effects for niacin suck. And people usually can't take it because of the side effects and they will stop taking it. So if you're just trying to increase someone's HDL, you're not just going to throw them on niacin. Try to fix whatever the problem is. Do they have high triglycerides? Do they have high LDL? Target one of those. Don't just say, I'm going to put you on niacin because I want your HDL to be higher. Okay? All right, so our money makers, our statins. Essentially what they're doing is they're inhibiting that HMG CoA reductase, which means that you'll have less intracellular cholesterol, which then upregulates those cells to make more LDL receptors, and then they will grab them out of circulation. So we're decreasing our plasma LDL concentration by causing an upregulation of the LDL receptors. So our drug of choice, if a patient has high LDL, and if they have coronary heart disease risk, so based off of our risk calculators and all the things of what we're going to do for those patients. Again, we talked about this. If they're under the age of 18, not necessarily approved, has been done, get somebody else to do it. Don't risk yourself, okay? So our clinical effect, again, repetitive, best thing for our LDL. Statins, LDL, okay? Statins, first line for LDL. You also see that it can reduce our coronary artery events. It can reduce coronary heart disease mortality. Lots of great benefits with them. Stroke, reduced. Again, the problem with these meds are the side effects and the monitoring that you will have to do if the patient does experience the side effects. So we talked about giving it at night because that's when most of our cholesterol is made. When you're talking about the newer drugs or if you're talking about a high intensity, most of the time you don't really have to give it at night because that dose is so high, the medication is still in their body, it doesn't matter. So if someone chooses to not take it at night and they're on a high intensity, when we're talking about our rosuvastatin or our atorvastatin, they're okay, okay? But you would want to optimize the drug and optimize this effectiveness by having them take it at night. If there is a reason why you are trying to start a patient on moderate, give them some time for their body to respond to it. Give it some time for you to see the negative trend or the LDL levels going down before you just try to increase the dose, okay? So that's what it's meaning by at least leave them on a dose for 4 weeks before you try to bump them up to something else, all right? Adverse reactions, we talked about this, are muscle issues, okay? So you have myalgia, which is just muscle pain, and then you can have your different myopathies, which are usually when those, your CK, you'll get their labs at baseline, and then you'll get their labs if the patient is complaining of symptoms like any muscle problems, because then you're like, oh crap, they have some myopathy going on. When you get their CK, it's showing you any type of muscle breakdown, muscle damage, and it can also be indicative of any type of inflammation that that patient is having. So they're not specific to just the fact that, oh, this patient is having muscle breakdown. If they also like just had some type of car accident or something, they might have more inflammation, right? So that CK could falsely be elevated and not necessarily saying that it's just from muscle breakdown. So just be careful for that in practice. On paper, if they have a CK that is elevated 10 times above that upper normal limit, then that's whenever you're saying, okay, they have myopathy. When you're looking at rhabdo in specific, that CK is, again, 10 times the upper limit. And then you see also that their serum creatinine is now being affected, okay? This is what causes a lot of people, whenever they say it's serious, because things start to shut down, you get into kidney failure, and that's why rhabdo is so bad. A lot of people say that their urine looks like Coca-Cola or like black, like a dark brown and kind of thick. That is something for you to let them know you need to go to the ER, okay? Don't even wait for an appointment for you. They need to go and get care right away because they could be going into liver failure or kidney failure, sorry. And it doesn't mean that that's necessarily what's happening. You also see this in a lot of patients who, in our age population, who just work out a lot. Rhabdo happens very often, but they need to know what to look for if you're putting them on a statin so that they know to go to the ER, okay? And then you see the liver toxicity, rare, but it's something that can happen. So you'll get their baseline LFTs, and then you'll check them again at 4 weeks and at 12 weeks. Again, something that is rare that can happen, but it can happen. And it is very serious when it happens. So make sure you get your baseline a month, 3 months, okay? I think that's the big picture from here. Muscle pain, statins, okay? They're going to be your headache. So these are our monitoring parameters. Again, some of the things that we just talked about are here. Making sure that you're checking that CK at baseline, but essentially with the CK, you're only checking it again if the patient has complained of some type of muscle, some type of myopathy. If they haven't complained of it again, you don't need to check it again, okay? And then you see how we're looking at our ASTs, our ALTs, and then our fasting. So I just want you to know those are the monitoring parameters that are listed here. Definitely getting these things at baseline are important. What happened? Yes.
Are we talking about muscle pain different than working out muscle pain?
Yes.
Okay.
It'll be more intense. It's very painful. Okay. I've never had it. I had a friend who had it, and she's a doctor, and she was like, I just thought I was sore. It took her 3 days. She's like, I thought I was just sore. It feels like that, but she said it was way worse, and then her urine changed right away. So that was where she was kind of ignoring it. She was like, oh, I thought it was just, like it was going to be fine. But then she said the pain, you know how you'll have that increase of pain and then it kind of drops down and you're like, okay, or you'll go work out again and it kind of goes away. Mm-hmm. She was like, it kept getting worse. And so that's what made her finally go in. Yes.
That doesn't have CK
Yes, because they make me sick. Yes. Let me remember to write it on here for myself. But yes, please get it at baseline. It's there. You missed it. It was there the whole time. All right. Okay, so on this, these are factors that can increase a patient having myopathy, which when we look at them, they all make sense, right? If I'm older, that's why we debate on if we're going to start that patient on high versus putting them on a moderate versus putting them on, like, sometimes they end up in the low category because that's all that they can take. If they are complaining of muscle pain and they are older, it's probably legit because, I mean, like, their body has been through it. If I make it to being over 75, don't be mean to me, okay? Be nice. Give me the max tolerated dose. Yes, our chart may say moderate. Yes, it may say high. But if we can give them something, it's better than nothing, okay? And give them what they can maximally tolerate without having some of those symptoms. And then just looking at all of these other things here, I'm not going to read it to you. Also looking at the fact that the grapefruit juice is going to be a side effect that comes up that we're going to talk about. They have to drink a lot of grapefruit juice. If they're over 75, they probably do drink a lot of grapefruit juice. When I'm old, I'm going to drink me a lot of grapefruit juice. But they have to drink a lot of grapefruit juice for this to happen. But again, it's something to let them know, because if they are doing that and then they start to feel muscle pain, tell them they need to back up off the grapefruit juice, okay? That's just one easy grab that you'll get. So know those characteristics that are listed over there. Okay, statin intolerance is going to happen. You are going to need to know what to do if I cannot take a statin, if I cannot tolerate that dose. So what you're trying to do here is decrease the myopathy and decrease the pain that I'm feeling. So you can change my dose, you can change my class. Try to change the dose first or lower the dose first before you're changing a class. Some people freak out when you put them on a new med. So if you're just like, oh, I'm going to lower the dose, they're more willing to do that, and then you can try to re-challenge them later. Maybe you just started at a higher dose. But changing their dose, changing the class, every other day dosing is kind of tricky, but it is also another option. A lot of patients will forget what day they're on. So if you do every other day dosing, you need to write Monday, Wednesday, Friday, like write out what the days are for them so that they know when their every other day is, okay? Because they'll be like, I think I took it today, and then they're going to come back in and they're going to tell you I still have muscle pain, or they're going to tell you I stopped taking it because I was still having muscle pain, okay? So when you write your SIGs, write out what days they're supposed to be taking it on. And then you see where it said to change the statin. Okay, if they're having severe pain, we are not going to torture them, right? Stop it. Stop the statin. Discontinue it. You can even let the patient know if the pain is that bad to discontinue it. Call your office. Don't just discontinue it and wait until their next appointment 3 months later. If they stop that statin, they need to call you. They need to write you a message so that you know to get them back in, and then decide on if you're going to change them, if you're going to decrease the dose, what you're going to do with that statin. Okay? And then you're going to need to get the CK, because remember we said if they had muscle pain, we're going to recheck that CK. If it's mild to moderate, you can have them stop their meds until you can have them come in to see you. Again, letting them know what they're looking out for so that they know if they're in enough pain to stop it versus if they can tolerate it until they see you. Because without them being on any medication, their LDL levels are going to be going right back up, which is what we're trying to prevent in the first place. And if we're going to potentially have to decrease that dose, we don't want them to be off of it for a long time. So anytime they're stopping it for any muscle pain whatsoever, just try to tell them that they need to talk to you. Okay? So you'll stop it, and then you'll decide if you're going to continue them on that same statin, decrease the dose, all of those options that we listed there at the top. And then if you can 100% correlate. The statins are what's going to always, no matter what you're doing, they have intolerance to statins, cause muscle pain. You can put them on the lowest dose and they're going to be like, oh, my muscles still hurt. You're going to have to switch to another class, which is what we'll talk about. So the patient that I was telling you all about, who looked super healthy, super fit, he couldn't tolerate statins at all. And he said, yeah, it's the same for everyone else in my family. They can't tolerate statins. And he told the provider that at the very beginning. He still started him on the statin because he was like, that was your dad. It doesn't mean that it's you. So he started them on the statin high dose. And the guy came back and he was like, no. So then he was very nice. He let him go to medium. Like he went to the moderate dose and he was still like, I can't. They went to low dose, every other day low dose. He still couldn't. So we ended up having to switch him. So you will have some of those patients to where they just have a complete intolerance and they can't deal with it. It's legit. Just switch them to something else, which we'll go through. All right, so these medications are renally cleared, and when you're looking at dosage adjustments for anybody who has any renal dysfunction, that makes sense. The two that don't have it are your atorvastatin and your pitavastatin that don't require the dose adjustment. So the way that you guys can try to remember those two is like, y'all are PAs, right? PA, and you feel like you're in a pit because you have two P's. So I don't want you to mix up the P's, okay? You feel like you're in a pit, so that's how you're going to remember, like, you don't need adjustments for the PAs. But the P with the pit, not the pravastatin. Our pravastatin is highly bound. So you will have some interactions with your pravastatin because it will displace other medications that are also highly protein bound. So now you will have competition. So the levels of those other meds can be increased or decreased depending on what's going on and who made it first. So you see with our warfarin, we probably have to end up doing some dose monitoring because you're going to have to adjust that dose 9 times out of 10. All right, your absolute contraindications when you are talking about your statin is if somebody has liver disease, okay? They cannot tolerate a statin. Because we have also some hepatic elimination, because we have the potential to cause that rhabdo, if they have liver disease, absolute contraindication, they are not allowed to have it. Also, if their liver enzymes are elevated for whatever reason, again, they cannot take a statin. Your relative contraindication means that you would suggest that they don't take a statin, but they can. You're just going to monitor, okay? I don't need you to remember the SIPs, just know that they have interactions with SIPs. And then with pregnancy. Pregnancy is unique, so this used to be like an absolute no-no, absolute contraindication. If you're pregnant, do not take a statin. They have since changed that to say, if essentially the risk outweighs the benefit, then the mother can take the statin. If you can have her wait until she's in the 2nd and 3rd trimester, that is better. But if it is a life and death situation and this is the only thing that is going to keep those LDL levels down for that mother, without the mom, there's no baby anyway. Unless you, yeah. So now it is not a absolute contraindication. It is a risk versus benefit decision. You will try them on a different medication. You will try to say, hey, we need you to work on lifestyle modifications. Limit how much LDL you're getting from exogenous sources. Let's see if we can try you on another med that we'll talk about later, but about acid sequestering instead. There's other options that we would try before we said, okay, I'm going to leave you on your statin or I'm going to put you back on your statin. Also in the same vein of protecting the babies, if the mother is breastfeeding and she is on a statin, she shouldn't be doing that either, okay? So again, we would try to see if we can switch the mother to a bowel acid sequestrant or see if the lifestyle modifications while she chooses to breastfeed is enough. You can also see if she can pump enough off of the medication, store it, and then be able to not necessarily like physically breastfeed, but give breast milk to the child is another option. All right, drug interactions. Again, I told y'all just understanding that you have some CYP interactions that are going to occur with our pravastatin and our fluvastatin. You'll have less interactions with those, so those are your drugs of choices if you have if you have a lot of interactions and you're trying to minimize because they have other meds that they're taking, then you're going to lean towards your fluvastatin or your pravastatin depending on what dose. If they need a high dose statin, this is not going to be something that you're going to be able to do. Okay. Grapefruit juice, again, we talked about it. You see that it can increase the risk of the myopathy, but again, that usually takes a lot of grapefruit juice and a lot of grapefruits. Okay. Reddy's rice. A lot of people take this because it is over the counter. It is a dietary supplement. A lot of people who have issues with high LDL levels will also try to do this before they go to like a prescription medication. So you need to make sure that you're talking to your patients always about what over-the-counter medications that they take. Because when you say, do you take any medications? They're like, no. They're only thinking about prescription meds. You have to say, are you trying anything also over-the-counter? Any eye drops? Any Tylenol? Like, point out the little small basic things so that that makes their mind think like, oh yeah. I asked this lady one time and I super regretted it. She pulled out a computer paper, a computer sheet, and I mean like every line was filled. She was on so many supplements. And I looked at my preceptor and I was like, can I tell her to stop taking all of this stuff? Like, we have no idea where to even start. So ask them because you don't know where an interaction could be occurring and the patient definitely doesn't know. I was like, why are you taking this? She's like, oh, I saw that one on a commercial. Okay, why are you taking this? Oh, my doctor 10 years ago told me to take it. Like, she has a new provider, but like she just never stopped taking anything. Okay? So ask them about those over-the-counters. So Reddy's rice is an additive effect that you're going to get with it. So that's essentially why you're avoiding taking that with a statin. That's the big interaction there. Oh. Okay. Fibric acids, which are another medication that we're going to talk about here shortly, can also increase the myopathy that a patient feels if they are still taking a statin. The biggest offender in this class is gemfibrozil. Okay? The other ones can still cause it, but not as much. So absolute, you don't want to do it with gemfibrozil. So a statin and gemfibrozil is a no-no. If you saw a statin and fenofibrate, you're probably going to be needing to monitor that patient and monitor their CK levels a little bit more because you're putting them on two medications that could increase that myopathy risk. Okay. Niacin, again, increasing the risk of myopathy. And then your other medications are listed below there, which is also increasing the risk of myopathy. So all of our interactions essentially are because we're trying to avoid the myopathy that the patient is going to get. Gemfibrozil, no. No. All right, so this slide is essentially everything that you just saw on the other two slides, plus ranolazine, ticagrelor, and warfarin. I don't think Dig was on there. Might have been. So this slide, look at what your interactions are. I don't need you to know what the recommendation is as far as like increase the dose to this, decrease the dose to that. I don't need you to know that. I just need you to know those drugs that it can interact with. Okay? Don't worry about the recommendations. All right, our fibric acid derivatives or our fibrates. Great class of medications. They are very good when we're talking about lowering our triglycerides. So the mechanism for this is that PPAR normally is stimulating the lipoprotein lipase to break down or remove the chylomicrons and the VLDL, which is they're bad, right? And remember, our VLDL is the cursor to the LDL. So if we can get rid of that, then inadvertently we're decreasing like our LDL, we're decreasing our triglyceride level, and it also can potentially elevate your HDL levels, okay? So fibrates are pretty good. This is the one that we talked about specifically looking at gemfibrozil. We would not be giving that with our statin, okay? Absolute, don't do it. And then you see with our gemfibrozil, if you eat with it, then you're increasing the absorption. You'll get better absorption, probably a better response for that patient with food. The other medications that are in here are your fenofibrate, which is also a prodrug for the fenofibric acid, okay? So our fibric acid derivatives, good for triglycerides, can also help increase our HDL. And then our mechanism of action that we're talking about is the PPAR alpha agonist, okay? What is also good about this medication, it's a medication to treat the side effects of another medication, right? So when we talk about our HIV meds, you'll see where some of them increase the triglyceride levels in patients. We can give this medication to help control or reduce the amount of increase that you see from those protease inhibitors that we would be giving the patients. Okay? So, sorry, let me go back. If they cannot use a statin, this is like a second line to a statin. This is not something that we are trying to add on to the statin. When we talked earlier, what medication did we add on to our statin?
Ezetimibe?
From the chart, yes, our ezetimibe, right? That's usually what you're adding on. This is a medication to where you're like, hey, my statin isn't working. I can use this instead of the statin. Okay? But again, best case for this, it has minimal effects on LDL. Usually what we are using this for is because we're trying to get those triglyceride levels down. If you had no options, they couldn't tolerate other things, then this is another medication that you could use for them. Adverse effects, myopathy is back again. Okay. The GI malignancy is still something that is not proven, so a possibility. So if you have somebody who has already had malignancy, any type of cancer, anything like that, try to avoid this class if you can, because there is still not enough evidence to say yay or nay on if this could contribute to those issues for those patients. Monitoring, just our LFTs, if you're going to give it with a statin. Are we going to really want to give this with a statin? No. If you have to, then you're going to have to monitor your LFTs. Also, you're probably going to be monitoring your CK levels as well. Pregnancy, some women will get elevated triglyceride levels when they are pregnant. This is safe to use once they hit their second or third trimester. Okay? Their levels have to usually be pretty elevated to where the provider is going to want to even put them on the medication. Usually we're doing that because of the fact that you don't want them to have pancreatitis. That's what you're trying to prevent in the case of because the mom is pregnant. So, second or third trimester, if we can wait our time out to that point, is when you would start these. That is when it is safe for you to use them. Okay? Drug interaction, we talked about this 1,000 times. I'm not going to say it again. And then our contraindication, same as before, kind of is almost exactly the same that we had with our statins. Also, what you can see here, the increased effects of their warfarin. So you're going to probably have to decrease your the dose of warfarin that you're giving your patient, okay? Because it's going to probably push them outside of their INR range. Niacin. Niacin stops your VLDL formation and secretion, which is good, right? Because now we're decreasing how much we're decreasing how much LDL can be formed, right? Because it was a precursor. So good medication, very difficult to get patients on the medication to control their levels. So you see it's very good for raising HDL levels. You're going to be using it to lower triglycerides. It's also comparable to a low intensity statin, so that range of, you'll have a minimal reduction essentially if you were trying to use this for that purpose. Again, pregnancy, you don't want to use niacin because of the side effects that we're going to talk about. So if they find out they are pregnant and they're taking niacin, discontinue it, don't use it. So our use, again, this is an alternative to if a patient cannot take a statin. Again, with this medication, the adverse effects, which are usually flushing, people say that they feel like they're just burning, like they're hot. You'll see them turn red. Usually starts in their face and then it goes down all the way to their feet. The flushing just feels really bad. They feel warm. Some people will sweat if they have like a super sensitive reaction to the niacin. Some people will also have GI upset with it. So just imagine just being really uncomfortable, okay? This is why a lot of patients don't tolerate it well. What you can try to do, and what, if I know a patient is taking niacin, I'll tell them even before that first dose, they can take aspirin 30 minutes before they have their dose of niacin to try to prevent the flushing. So you're doing something that we don't like to do, giving a med to prevent a side effect of the med, okay? But aspirin 30 minutes before can reduce it. You can also have them take it with food. That should also reduce the flushing that they have. And then what's commonly seen is that they'll give little doses at a time. So they'll slowly titrate that person up so that they're getting used to kind of maintaining, not being so sensitive to the medication to where they won't have so much flushing if they have it at all. So that's why you would do this slow titration. Again, most of the time, dose is going to have to be reduced. Liver toxicity, another thing that could occur. What they have seen is that there are several different formulations of niacin. Of course, with your IR, it's going to hit you faster, so you're going to have flushing a lot faster. So most of the time, you'll give a sustained release. The downside to the sustained release is the possibility of you having the liver toxicity. Big thing here that you're going to watch out for, diabetes. If a patient has hyperglycemia, this is not a medication that you will want to use, or you need to make sure that your patient is still monitoring their blood glucose levels. A lot of patients who have diabetes, we'll tell them to keep a log, but then once they get comfortable, they're in their groove, they know how to manage their diabetes, they know what to avoid, they know what to feel if they're hypo or hyperglycemic, they don't monitor anymore. But if you're going to give them niacin, they need to continue to monitor their glucose levels. Okay? You may or may not need to, if they're on insulin, change their insulin doses. You may or may not need to also increase their if they're taking like metformin or something orally, they may need to increase their dose. Less likely to see this with the sustained release, still a possibility though. So if they are uncontrolled, you already know your patient has no idea about how they're living life out in these streets. Do not give them niacin, okay? If they are uncontrolled, you don't get niacin. Because if I send you into a hyperglycemic state, you're not going to know what to do. You're not managing yourself well as it is. And now I'm giving you something that can make you worse, okay? So don't give it to them. Hyperuricemia, okay, they're inhibiting the secretion of uric acid, so then you'll start to think about more, thinking about gout and hyperuricemia, more of the uric acid coming out in that urine. These are the different doses that you can see. You see how large those doses are. It's a lot of pills for them to take. People are not adherent. They don't like it. They stop it. Your contraindications, again, looking at your liver disease, gout, all of this makes sense, right, because of our adverse effects. So you're going to monitor those LFTs, and then you're going to check them out every 6 to 12 weeks. And of course, every year they should be coming in. Every 3 months they should be coming in to just make sure that they're okay, that they're not experiencing any of those side effects, and that they are actually still adherent to the medication. Our bowel acid sequestrants, these are our C drugs, as I like to call them. So again, remember when we were talking earlier, our bowel is made from cholesterol. And so after they are produced, what ends up happening are the bowel acid sequestrants bind them from circulation, which then causes the liver to like uptake more cholesterol and make more bile. So that's how these work. They're not actually absorbed, so you're going to need to tell your patients that they're going to see it in their poo-poo. They get freaked out. They think that the medication isn't working. It looks like it comes out essentially intact, is what it looks like to them. okay? So that's why you see the resin is excreted, it's not absorbed. Some patients will be like, oh, I saw this. Like, I don't know who examines their poop that much, but let them know that it is a possibility that they can see it. These are okay at lowering our LDL levels, but you can see where you can get a possible increase in your triglyceride levels. So just monitor your patient to make sure that you're not putting them causing you're not increasing their triglyceride levels. Okay. What else did we say that we can use second line to our statins that we've talked about so far? We had fibrates, right? Okay. When you are talking about our statin, am I going to give my gemfibrozil with my statin, my simvastatin? No. Okay. So a good option for our pregnant patients who can't take statins, this is what I was talking about, our C drugs, our bile acid sequestrants. Thinking about it, this medication isn't absorbed when we go back to like its mechanism, right? So that way I'm not really harming this pregnant patient because she's not going to really absorb any of the medication. It's just going to sequester out, and it's something better than nothing. Even though we're not going to get that same LDL lowering effect that we're going to get with the statin, we're getting her some lowering with those lifestyle modifications. Always remember to include lifestyle modifications. That is always a part of their treatment. You can see the clinical use here. We talked about it. Although a side effect of this medication, which is that it decreases absorption of other medications, you can see where sometimes we can use the medication for that benefit. So you see where it says reduces the half-life of some medications because it's going to prevent it from being absorbed. Also to note on here, I just want you to know that they're all C drugs, and then looking at the fact, I don't need you to remember the doses. You know that all of these can be used in pregnancy. But looking at the Welchol or the Cosavelum, this one has less side effects and less GI issues. Okay, because these patients will experience a lot of GI distress and like gas, bloating, constipation. That one has the least amount of side effects. It's also one of the newer drugs, so that's why it has less side effects. They made it for that reason. Okay, so know what the drugs are, know which ones have the least side effects. Looking at your adverse effects, just said this, you have GI distress or constipation. A lot of patients will experience this. Just have them increase their fluids, increase how much fiber that they're going to take to try to help them not be constipated. When we are administering them, we talked about this a little bit yesterday, 1 to 2 hours before or 4 hours after you're giving any other medications is good for you to prevent them from displacing or altering the dosing that you would need to do from these other medications. So it will work for your thiazides, beta blockers, all those things. Contraindication. Because we said that a side effect was that they could possibly increase triglycerides, we are not going to use them if someone has elevated triglyceride levels. So if they're over 400 already, we're not going to give it to them. Okay? I'm just going to go ahead and finish so that we don't have to do this tomorrow, all right? So give me like probably less than 10 minutes. Our Zetia, this was our medication that we kept adding on, right? You are not being hit with, you're not meeting goal with your statin, or if you cannot tolerate a statin, this is the one that I'm adding on. The mechanism of action for this is it's inhibiting the absorption of cholesterol from your exogenous and endogenous pathways. So that's what's pretty cool about this one. So even if you're not eating it, it's still going to help prevent that endogenous pathway that's happening. Is going to help us prevent absorbing that cholesterol as well. So it's good with lowering our LDL. Still not comparable to a statin. It's more of a low dose statin. So still less. Minimal HDL increase and minimal triglyceride decrease. So again, it's just giving us a little boost that we would need with our statin, or if they just can't tolerate it and we need something, this is something else that you could give a patient. You see how it says adjunct therapy for the statin because it's going to increase the LDL level by at least increase the LDL reduction by at least 25%. Pregnancy, they found that there were some adverse effects in animals, so I'm not going to give it to a human, right? So we're not going to give it to a pregnant patient. Interactions, our VAS, we already know that they're going to interact with that. Everything is going to interact with those, which is why we have our 1 to 2 hours before, 4 hours after. And then here you can see the combination therapy. So what they found is that if you give them together, you can potentially lower the dose of the statin, which is good because I'm probably going to prevent what side effect? The myalgia that they're going to get, like any of the myopathies. Okay, so this is just showing you that these do come in combination therapies where you can, if you have a patient who is experiencing side effects, you can try to see if you can put them on one of the combos that already has the Zetia. You'll probably have better adherence as well because they're taking 1 pill instead of taking 2 with you adding on the ezetimibe to the dose that they already have. Okay. Your PCSK9 inhibitors. These are newer medications. They cost a lot of money. And so if you're going to send somebody on the outside, just be ready to know that they're going to spend a lot of money for them, and you're probably going to have to fill out a prior auth, maybe a medical necessity form to try to help that patient with the copay. But essentially the mechanism for this is you have the PCSK9 enzyme that binds the LDL receptors to promote the LDL receptor degradation, right? So when it's inhibited by this drug class here, the LDL degradation is promoted because now there's more receptors that are available to bind the LDL out of the plasma. So that's what they're calling receptor recycling. So you're pulling more LDL now out of the system. So that is what that is saying. Here you can see that they are highly effective. So when we were talking about bypassing a statin or adding on the Zetia in certain situations, this is the class and this is why. They have very good, they're very good at lowering the LDL levels. You can see that there's also now some mortality data that they're pulling that's showing that it's beneficial. As time goes on, I'm pretty sure that that's going to increase. So they both have the mortality benefit that we were talking about. And then again, you see that it's an adjunct to their diet, adjunct to the statin that the person is taking, usually reserved, okay? If you cannot get them at goal with that statin or adding on the ezetimibe, this is where we would go. Or like our other patients, if they cannot tolerate the statin and you just have them on ezetimibe or you just have them on one of our other medications and they're still not at goal, we can say, okay, now we can prove why this patient has medical necessity for having our PCSK9 inhibitor. What you do see here is that they are sub-Q. They are injections. They are not like our other medications, which we were talking about. All of those were oral medications. These are sub-Q. You see that it's every 2 weeks or once a month with the evolocumab. The storage, all of that stuff, you're not going to really need to, you can talk to them about it. They should be refrigerated. You shouldn't be keeping them out of the refrigerator for a long time. A lot of patients also say that they like whenever it's not, when they don't give an injection and it's cold. So they will sit it out at room temperature. Just make sure that they don't forget. If they set it out, have them put on a timer for maybe 30 minutes or so, that they need to go back and they need to do their injection. With your protecting them from light, a lot of patients, you gotta tell them, okay, don't just, it's not like they can't have it in here, okay? Like it's not like protected from light that way. Because if they're gonna leave it out for 30 minutes, it's gonna get light. But it's like saying don't leave it in a highly lit place for a very long time, which they shouldn't because their refrigerator light should be off when they close it. You see the cost. Cost is insane. And this is what they're spending every 2 weeks. This says per dose, okay? For us, on the inside, when we're dealing with monopoly money and they're going to an MTF, this doesn't mean anything, right? But if you send me on the outside and this is not paid for, this is a big hit on me, okay? So that's why you'll see that it's highly reserved. Biggest side effect that they've been seeing is that people will have the nasopharyngitis or like flu-like symptoms and injection site reaction, which you'll get with any type of sub-Q IV formulation. And essentially with the nasopharyngitis, they'll just get a cough or nasal congestion. Give them another med to help them if that happens to them. Omega-3. Okay, safe to use in our diabetics, unlike which medication could, oh yes. Yes. Flu-like symptoms. I don't like that they put in, listen, I say this too all the time. When I go and get my flu shot, I'm like, oh, I have the flu. Like it is, I'm not, no, flu-like symptoms. Flu-like symptoms. Look, let me fix that too. I can't write with this, so I'm not even going to try. So I can't trick you with that one. All right, our omega-3, this has been back and forth on if it's going to be on formulary, if it's not going to be on formulary. See what they're doing by the time you get out to prescribe. But this is a great alternative for people. They are huge pills. When I say huge, I mean like they're like this big and they're gel caps. And they stink when you open the bottle. They smell like fish. When people burp after they've been taking them, their burp smells like fish. It's just, but they work. So the omega-3 that we usually have, those big ones that I'm talking about, it has the EPA and the DHA in it. That's what's in the fish. And so that's why they have like that burpy, the fishy smell to the capsules, as well as whenever the person like burps, and sometimes their body odor can even start to smell fishy, and nobody don't want to smell like a fish. Mechanism, not very clear, but you see that they're thinking that it has something to do with the acyl-CoA. But again, it does help with lowering our triglyceride levels, which is why a lot of people use it. Some people also can take it as a supplement. You can buy it over the counter in different dosing than what we have behind the counter, but some people will also be taking this over the counter. Can raise up the LDLs when your triglyceride levels are extremely high. So again, like I said, you can buy this over the counter. If someone is, if you're having a patient who has high triglyceride levels, ask them about this as well. This is something that a lot of people take as supplements because you see it on TV all the time. When I stay up late at night watching my murder mystery shows, I'm like, oh, take your omega fatty acids. Like, stop telling people this, please. Modest HDL increase that we see. So with this one, we are getting some benefits whenever we're talking about the side effects when comparing it to niacin. So again, prescription product, I'll go into that a little bit. But prescription product, we have our Levasa or omega-3 acid ethyl esters, which has both the EPA and the DHA in it. So it has both types of the omega-3. You can also have increased bleeding with this because of the pathway, which is on the next slide that I told you is just FYI, because I'm going to tell you this way. Because of it inhibiting possibly the platelet aggregation pathway, you'll see that you'll have increased, you can potentially have increased bleeding. It is more profound if you have a patient who is taking more than 3 grams a day. So that's what that's saying there. If they're allergic to fish, if they don't want to smell like fish, this is not for them. Do not give them their omega-3. If a patient has very high triglyceride levels and they are pregnant and they could potentially get pancreatitis, this is another option that we can give that patient to help lower those triglyceride levels. You also have your isosapent ethyl or your Vascepa, which only has your EPA in it. Again, they're going back and forth with which ones they want to be on formulary versus which ones they do not. If a patient has been taking the Levasa for a long time, you can write them a prescription for it to go on the outside if we're no longer carrying on MTF. I've seen this being picked up and dropped off several times on the formulary, so it just depends on what they feel like, the P&T committee feels like that day, that month, okay? But those are our 2 options that we have. And then again, over the counter, you see that it's available for the patients. Adverse effects, we talked about those, the burping, the fishy smell, fishy taste in their mouth, not fun, and then the increased risk of bleeding. FYI slide on how this causes the increased bleeding. Again, it's just affecting our platelet aggregation, so that's why we have this is the full pathway if you want to be extra, extra, extra smart. Looking at our Ficillum or Metamucil, this is our bulk forming laxative that we can have that also has some LDL lowering properties with it. They're not very significant, but this is an option for a patient if they want to not have to take medications or feel like they're taking medications. Adverse effects, bloating, gas. That's all. Okay, this is just a summary of all of the things that we have talked about, and if you're looking at trying to look at your low intensity statins, that's already on your other slide that you had available. Again, for patients who can't tolerate that high dose, you're going to go down to moderate. If they can't tolerate the moderate, you're going to go down to low. Non-statin, this is just talking about all the other medications that we talked about and what kind of tactics you can do if your patients are still not hitting goal. So you can make sure that they're being adherent to their medication. That adherence a lot of the times will fall into if they're experiencing any myopathy, so just make sure that they are not and that they are taking their medication before you decide to change their dose or change their statin that they're on. Looking at adding that non-statin, so when we talked about adding the ezetimibe to their regimen, that's also an option. But again, it's not showing that it can further reduce mortality, but we know with our statins that you have a decrease in mortality as well. So it's not like you need to add on something to increase the mortality benefit. You're already going to get that with your statin. You're not increasing it by adding on a pill burden to that patient. And then looking at our LDL goals, just knowing that if you add on another medication to a statin to get them to goal, that you could potentially decrease the dose of the statin that they're taking so that they don't start to experience those myopathies. Some patients can take a statin for years and years and years and be fine, and then they will come to you and say, I'm starting to feel muscle pain. We had a patient who had been on a statin for 15 years and all of a sudden started having myopathy. Okay, so it is possible that it can happen. In that situation, we decreased their dose and we added on the ezetimibe to try to keep them their LDL levels maintained, but we were able to decrease the dose of the statin and then they were okay again. Okay. So quick check on learning before y'all go. Which of the following medications is likely to cause myopathy or rhabdo in a patient taking simvastatin?
Hey.
Wrong. No, I'm just kidding. It's A. Hey, okay, and then the second question. This is more difficult because y'all don't know all of the levels yet. You don't know the doses yet. But because of the fact that this patient had that recent MI, yeah, okay. Examples of what your questions will kind of look like, which is why you need to know your doses of your statins, okay? Remember your high, remember your low, everything else goes in the middle. Okay? I'm around if you guys have any questions. Let me know if you need it.